he had problem of connection, but the other one is with us. So
Okay.
I'm happy to announce Professor Dimitroulas, who is in the chat room, and we expect to see his case.
All right.
Good.
So thank you, Sophia, very much for the introduction, as well as for the invitation to participate again in Athens CMR level. I'm a rheumatologist from University of Thessaloniki, and so we will discuss a case which presented to us and to the cardiologist with febrile syndrome, cutaneous manifestations, and elevated troponin levels, and we will see how this case was quite educational for both cardiologists and rheumatologists, and which were the messages and the benefits from registrars as well as for specific doctors. So this was a very young 25-year-old female, former smoker, who had a history of Raynaud's phenomenon since adolescence. A few months ago, she presented with acute onset of fever associated with severe thoracic pain, which she experienced for 3 days. So she visited the emergency department, where the fever was confirmed and was quite high, but in the same time she had very high elevated troponin levels as well as CPK levels. These symptoms and biological findings were also associated with high inflammatory markers. We can see ESR at 49 and CRP about 5 days upper the normal limits. So this lady was admitted in the cardiology department. She had an echocardiogram which showed mild hypokinesia of the cardiac wall. There were rare ectopics in the 24-hour Holter examination, and in the cardiac MRI, there was some myocardial edema with LG enhancement, which were suggestive of myopericarditis. We can see some picture here, and we can taken all together the clinical presentation, the biochemical markers, as well as the echocardiographic and cardiac MRI findings. This diagnosis of myopericarditis were established. She was started on cardioprotective treatment by soprolol and ramipril by the cardiologist, and at this time they requested for a rheumatology opinion. So when we saw the lady, we can see in the heads that there was some erythema, which was Raynaud-like, without any ulcers. And in this case, we can discuss with cardiologists how they will get some educational benefit from this case. They could be able to recognize from the clinical examination some symptoms of systemic diseases associated with severe heart involvement, such as Raynaud's or erythema. These patients are quite commonly can present with myocardial involvement. So the rheumatology evaluation confirmed the presence of Raynaud and pharyngeal edema, presence of myalgias, and some feeling of muscular weakness. The patient had no history and no clinical manifestations of serositis, arthritis, skin psoriasis, malar rash, ulcers, Zika symptoms, or renal involvement. Negative family history for connective tissue disease, and the working diagnosis taking into account the clinical presentation, the fever, the high CPK levels, as well as the Raynaud's and the skin erythema, was connective tissue disease, mixed connective tissue disease, scleroderma, or dermatomyositis. The clinical examinations, and particularly the specific rheumatological serologic tests, revealed high adenuclear antibodies titer and urine RMP positivity in very high titers. These tests were suggestive of mixed connective tissue disease with myositis overlap. Blood cultures, urine culture, and were negative. Urine culture revealed some infection by Escherichia coli, which were easily treated with a short course of antibiotics, and quercetin was negative. So in this case, and taking into account the severe myocardial involvement, which was revealed in echocardiogram with reduced ejection fraction and hypokinesia of the left ventricular wall, the lady was started on quite aggressive treatment with IV methylprednisolone, three pulses, 750 milligrams per day for 3 consecutive days, which then was switched to oral methylprednisolone with some daily tapering. In the same time, we had to do the myositis workup. We said a myositis panel, which was negative. Capillaroscopy did not reveal any significant abnormalities because although the lady had a history of Raynaud. Muscle biopsy showed non-specific myopathic changes, and an EMG had a myopathic pattern with no any specific changes suggesting inflammatory myopathy. So if we go back, we can see that the benefits from a cardiology leading with this case was the identification of skin changes suggesting of Raynaud's, which is the characteristic tricolor changes, updated advances in serological tests. So myositis panel is a specific panel of antibodies associated with inflammatory myopathies, is relatively new, novel development in the management and the diagnostic workout of myositis. Also, the cardiologists could benefit by the way and the dose and the way of administration that we use immunosuppressives and particularly steroids in order to manage and to treat the inflammatory infiltration in the myocardium. And finally, they may be aware of capillaroscopy. They may get themselves familiar with this method of assessing the microvascular function in the capillary vessels of the nail. And over the last year, despite the fact that video capillaroscopy has been considered a rheumatological investigation for assessing patients with Raynaud's, we can see that over the last years, there are several developments connecting capillaroscopy with several different aspects of cardiovascular disease, heart failure, pulmonary arterial hypertension, coronary artery disease, peripheral artery disease, and stroke in different subgroups of patients, and not only patients with rheumatic diseases. We can go back to our patients because any myocarditis associated with fever should be investigated for several infections, for several pathogens, including viruses, which were negative, as you can see here. And we can see that following the completion of IV pulse methylprednisolone therapy, the patient became afebrile. There was some skin involvement. There was normalization of biomarkers, namely CPK and troponin, and she restored a muscle strength of 5 to 5. Then she had a repeated MRI scan. The pictures, unfortunately, are not very good because from the technical point of view, we don't have very good MRI scans, and technological equipment in the hospital is not very good. But however, the second CMR showed regression of myocardial edema and recovery of ejection fraction, as well as resolution of hypokinesia in this lady. So following the initial treatment, then the patient had cyclophosphamide infusions and in the same time, given her young age, she gets some protection for gonadal toxicity with a GnRH analog, and now there are no problems with her gonads, hydroxychloroquine, and following the cyclophosphamide, she is on regular treatment with rituximab 1 gram every 6 months. And she has already completed the first cycle of treatment. At the same time, she continues with bisoprolol, ramipril, vitamin D, calcium, and supplementation. And currently, she has stopped steroids. And the last clinical evaluation by both cardiologists and rheumatologists was normal. She had today, by chance, she had a blood test which was entirely normal. So, which are the educational benefits from the clinical case from cardiorheumatology from a rheumatology point of view, from a registrar? So there was a diagnostic challenge to understand that myocarditis could present as the first primary symptom of inflammatory myopathies or even other inflammatory systemic diseases such as lupus, vasculitis, or systemic sclerosis. So also to learn to differentiate inflammatory myopathy-related myocarditis from viral myocarditis using interpretation of clinical, serological, and imaging data to gain a experience with mixed connective tissue disease features in patient, and to have some experience about the imaging utility of CMR to detect myocardial edema and LGA, which are both crucial for diagnosis and follow-up. Therapeutic lessons about, as we discussed, the understanding of importance of early high-dose steroids and escalation of immunosuppressants, as well as clinical reasoning, appreciate the need to interpret antibody-negative myositis with systemic features, namely Raynaud, peringeal edema, and adapt management accordingly. So this also the benefits from the clinical case. We have bridging disciplines. This case illustrates how collaboration between rheumatology and cardiology ensures early recognition and treatment of cardiac involvement in connective tissue disease. There are several clinical implications, particularly about CMR and other surrogate markers which can identify subclinical or atypical myocarditis, guiding timely immunosuppression and preventing irreversible damage. The impact of research and practice, which reinforces the need for joint protocols in evaluating cardiac symptoms in patients with autoimmune diseases, and any future perspectives highlighting cardio-rheumatology as a growing field where shared expertise leads to improved patient outcomes, particularly in rare but severe complications such as inflammatory myocarditis in this patient. Thank you very much for attending this short lecture, and now we can discuss its opening questions.
Yeah, anything to ask or to comment? No.
I don't know. Are there questions in the chat? Maybe, I don't know.
No, there are no questions in the chat.
Okay.
We can ask questions.
I would be interested. Did you also measure the T1 in that MRI study?
No, unfortunately not. I know T1 and T2 mapping, but unfortunately there is this possibility is not possible in the MRI scan of the hospital.
Yeah, I think the MR images they look quite good. I think the quality of late enhancement is quite good, and I think there was a more or less circumferential enhancement at the surface of the heart, and I think probably it was not only myocarditis, but there was probably also a component of pericarditis.
Yeah, this is an inflammatory myopericarditis syndrome. I think this is now it's well described, and also in the recent guidelines of international cardiology associations, this inflammatory myopericardial syndrome is described quite accurate.
Mm. And I think by treating early and aggressively, you probably prevented the progression of pericarditis, the development of pericardial effusion, and also the loss of myocardium. And I think if you have a chronic disease that relapses over the lifetime of a patient, and if each time you lose a certain amount of muscle, you deteriorate step by step the left ventricular function, and patient can go into heart failure and will have then the need for much more aggressive treatment from the cardiological point of view. So if you detect early a boost of the disease, for example, by looking with MRI, and you start treating early on, you can prevent a much faster progression of the disease.
And this is very important because even for cardiologists, because if there are general symptoms or other symptoms which may be associated with a connective tissue disease, we need to treat early. And in this case, there is a clear indication for steroids, which is not the case in a viral myocarditis, for example.
Yeah, and I think it would be good to someone install the T1 mapping, because this chloroquine, hydrochloroquine treatment can produce also a chloroquine associated cardiomyopathy. Yeah. Then you get these accumulation of sphingolipids in the lysosomes, and function can go down. And this is typically associated by a decrease in T1. So if you have the basic disease of the heart related to the rheumatological disease, you may have later on an overlap of another disease which is caused by chloroquine treatment, and you could then differentiate the different components that could produce a decrease in cardiac function. If T1 goes down, then you know that you have some toxicity of chloroquine on the heart. So starting now measuring T1 would maybe help later on to understand when function goes down, what is the reason for that. Yeah.
Okay, but don't hydroxychloroquine can cause some degree of myocardiopathy, but this requires, as you said, the cumulative action after several years.
I think I'm not very specialized in that chloroquine cardiomyopathy because it's really rare. But I would expect that this takes time to develop. But maybe it depends on the individual patient, the background of the patient, of course, the doses and so on. But it can happen, it can occur. And if you start with a baseline value, then later on you have something to compare with. So it could be helpful if you start this treatment. Yeah.
Okay.
Can I ask you something? Why you didn't use colchicine, which is efficient in both pericardium and myocardial inflammation?
Myocardial inflammation, I don't think that there is any specific guidelines in a patient.
But for pericardium, there is.
Yes, but you treat both with steroids because...
yes, but irrespective of steroids. Steroids are for the underlying disease mainly. For pericardial inflammation, colchicine has a specific value. So maybe we can get something more for this patient.
Yes, but in the setting of a systemic disease, I think that there are the steroids can have the action of colchicine. We have a myopericarditis and not a pericarditis alone. So I think that as long if there was any persistent pericardial effusion, we may consider for this, but currently the patient has no pericardial fluid, nothing at all in a recent echocardiogram.
But if you have recurrence of the pericarditis, maybe you should consider. Yeah, and anakinra also, because this combination works better than...
Yes, but the patient has a systemic disease. Anakinra as an indication for idiopathic pericarditis and not for a pericarditis.
Even in systemic diseases after lupus, they use it in Harvard.
Yes, but in this case, you need to see the whole picture of the patient and the other manifestations that you need to choose a drug which is suitable for all manifestations, for the overall treatment of the patient. And in this case, we also had muscle involvement, we had the fever, and that's why we proceeded with steroids and then an immunosuppressive treatment.
I have a question for that. I would like to profit to have a rheumatology specialist in the discussion. What is in this patient, for example, the typical marker that tells you the level of treatment? I mean, you started with a high treatment of immunosuppression, then you went down in the steady state. Now you can say, can I go out of all the treatment, or I need a basic treatment, and when do I have to increase again? So the activity of the disease, what would be in your hands are the markers that tell you the activity of the disease that can guide you on the level of immunosuppression you want to give?
Well, the activity of the disease, if we go back, when she was initially presented, she had fever, high inflammatory markers, high CPK levels, which are some indications of disease activity, and also troponin. But as a rheumatologist, I don't want to interpret the results of troponin, because we need to have combined assessment with cardiologists, and I'm not an expert to evaluate such. So at the moment, the patient has normal inflammatory markers, normal CPK, and no clinical symptoms. So we've been able to stop steroids without any significant relapse of the disease until now, and then we will reduce the steroid, the maintenance therapy gradually, and we will evaluate the patient to see if there is any relapse. But the markers is the clinical presentation of the patient. We expect, if something goes wrong, to do again fever, to present with fever, and probably with some muscle involvement with high CPK levels, as well as CRP and ESR, which are not so specific, but they also may be indicative of a disease. There is a question. I think there is a question in the chat. So it was Minoka. Which is Minoka? It's a type of myocarditis?
No, it's a type of myocardial infarction.
So troponin elevation, myocardial infarction, and no obstructive coronary artery disease. So this is a damage of the myocytes, but not caused by coronary artery disease, but another reason. So could be inflammation, for example.
Yeah, could be. But I assume that this is an umbrella covering several different pathophysiologic. Okay, so probably it is.
Yes, but the MRI pattern is different. If it is Minoka, it should be subendocardial or transmural LG, not subepicardial LG.
Okay.
I think if you have the diagnosis or suspicion of Minoka, would be good typically to make an MRI to see what is the reason, the etiology behind this Minoka. And in this case, it was inflammation of the myocardium that causes damage and troponin elevation.
So there is also another question from the same. Can this young girl do sports? Okay, this is not. I don't see any contraindications in that, but this is mainly in the cardiologist, I think, field to decide based on the heart function if she's able. I don't think that there is problem, but probably she has to do something gradually. Okay, to start. I don't think any issue. I cannot see any issues in this, as long as the underlying disease is well controlled and the cardiac function is normal. But again, this is something that should be discussed mostly with cardiologists. But we can assure that the underlying disease is well controlled. And there is another question which I think that is applicable to to Sophie, when should she do a follow-up with CMR?
Look, I would like to have a CMR examination maximum at 6 months after the initial CMR, or even earlier if she presents new symptoms. Of course, yes. I would prefer to have the next CMR in the right machine when I can get information about T1, native T1 and TCV, and also T2 mapping, in order to get more information, which I don't have now. Because for rheumatology, if you apply only the traditional CMR indices, it's a rather poor CMR evaluation, providing only part of the information we need for these patients. Because if there is an increase in T2 mapping, it means that there is ongoing edema in the myocardium, and we should keep it in mind and make the relevant decision. And if there is increased native T1 and TCV, it means that starts cardiomyopathy potentially, or it is part of the increasing inflammatory activity. So we have to evaluate all these examples. Or maybe we discover new LG areas which we don't know, or we were not able to discover using an old MRI system. So it's important for this type of patients to have a full agenda of MRI indices in order to make a final decision and create a CMR profile of the patient, just because they are chronic diseases and we have to know what is going on. When they have an acute event, nobody can exclude the potential to have another acute event or another acute event during the course of the disease. So it's important to have the right profile at the acute event. So we have to have all details.
Yeah, I think we could maybe add the idea that if you have a damage in the myocardium, troponins go up. But if you have, saying, 1 week of damage in the myocardium and you don't measure in that week troponin, you don't know that. But these damage in the myocardium will cause a certain amount of late enhancement of scar. So if you image after 6 months or 12 months, you have like the sum of all episodes of myocardial damage that occurred. So if you say, I see the damage with troponins, I only see the damage when it happens now, but I cannot see the damage that happened 1 or 2 or 3 weeks ago. If I do late enhancement, I have like the sum of all damages that happened in the past. So you might miss damage if you don't do troponin saying every day. So it might be by chance, if you do measurements by troponin, that you see it. However, if you do an MR scan after 1 year, for example, you then see all the damages that occurred over this 1 year period. And if you have then more scar after 1 year, you see that probably the disease is not under full control. So that can help. Yeah.
Yeah. Okay.
So in which case do you usually ask CMR in your hospital? Which cases?
In my hospital, or in the hospital?
No, I mean Professor Dimitroulas, not in your hospital. I know.
It's not up to. It's not required. We just we have some complementary role because these patients are usually it's not easy to perform a CMR scan in our hospital because this patient there is no. We don't have the possibility to have cardiac magnetic resonance scans in my hospital. This is another hospital in our city where patients are usually transferred after appointment to have the CMR scan. So we don't have the potential to ask very frequently CMR scans, and mainly this is and usually they are requested and they are organized by cardiologists because these patients most of the times are admitted in cardiologists. Okay, we don't do very often. We request from cardiologists to have these patients MRI scans, CMR scans.
Okay, long way to paradise.
Yeah.
However, you can get a lot of information even in your outpatient clinic. I mean, most of my referrals are coming from rheumatologists, from their own private and from the private clinics where they have questions regarding the patients, not for hospitalized patients. So, and usually they have most of the other indices normal. However, the MRI could be severely abnormal. That means, we discover things that we couldn't imagine to find. Mixed patterns of fibrosis, silent inflammation, because in the past we believed that lupus is expressing always with pericarditis. And then came the idea of myopericarditis, but we believe that it is something very rare. Now we know that we can discover myocardial edema in lupus with or without concurrent LG, and we had some sudden deaths with only edema. The patient recovered, and then we didn't identify any LG, which means that edema is not so innocent as we thought in the past, and maybe involved also in the process of sudden death without any evidence of scar. It is the same in fulminant myocarditis, which without autoimmune background. In patients with fulminant myocarditis have an explosion of edema without LG and with normal left ventricle, just because everything happens immediately in 1 minute, and there is no chance to develop adaptive mechanisms. But we see always the edema, which is the first protest of the heart against any provocative factor, against any causative factor. So you have to be very careful even with edema, not only with LG. And if you cannot assess it, or if you don't assess it, you miss the half of the case. And edema can be assessed without contrast agent, even using the simple STIR sequences which exist in every magnet. Of course, STIR is not the ideal way, but it can give you many information about recent inflammation and about persistent inflammation if you perform serial evaluation. So we have to work with things we have, but we have to use. We have to use all the agenda we have in a magnet, even if we don't have the most sophisticated approaches. So okay, thank you so much.
Okay.
I hope you find the potential to do more and more CMR and learn more from the modality, because it's really exciting and it will change the way you think about cardio-rheumatology, and you and your colleagues cardiologists. And I hope that the training in cardio-rheumatology will be promoted. And this is the topic of our next session. We have 15 minutes for the next session. Let's have a short break. And 6:30 we'll come again to discuss about education in cardio-rheumatology. So, Professor Dimitroulas, stay with us. You are in the panel.
Okay, I don't think that I will be able to stay. Okay.
If you cannot be able, okay, just keep in mind my advice to include CMR in your life.
I have it, but there are different in Thessaloniki.
I know that you like it, so find the right people and go ahead.
Okay, all right, thank you.
Thank you. Hope see you in Thessaloniki.
Thank you very much.
See you.
Okay.